second presentation will be from Mackenzie and Sharlene Rowan. Mackenzie has been working in the NHS for 25 years. He was a frontline paramedic for 18 years before moving across to mental health services, where he is now the interim head of physical health. Mo has gained a vast amount of experience and knowledge in skills in emergency and urgent care, but he's passionate not only to improve the knowledge and skills of staff, but dealing with confidence in physical health conditions. Sharlene Rowan has been working in the NHS for 20 years, 15 years in learning disability services in both frontline care and then latterly in community services, where she specialised in bespoke assessments for people with autism and learning disabilities. A career change 4 years ago now sees Sharlene as Medical Devices Safety Officer for the Trust, looking at patient care from a different perspective, how care can be managed or supportive with effective use and access to medical devices.
Hello everyone, thank you for having us today. So I'm Sharlene and this is Mo, and we form part of our very small physical health team from Sheffield Health and Social Care. So to give a bit of an overview then of our services, mental health care delivery has seen a lot of changes over the years, with growing evidence to suggest that physical health care and support has a beneficial effect on sustained mental health recovery. Mental health care is no longer isolated to just a specific mental health condition, and it's much more related to the physical health, and we need to factor that into care. So Sheffield Health and Social Care support a range of needs, including bipolar, multiple personality disorder, schizophrenia, dementia. We've got eating disorder services, we've got learning and autism services, we've got perinatal. We also support a lot of our vulnerable community groups, and we have longer term neurological conditions that we also support. In terms of physical health care, we have to be responsive to and manage known unplanned events. So for example, cardiac arrest, chest pain, use of ligatures, which is quite frequent in our services. But we also support patients who are living with ongoing physical health conditions. So that could be anything from diabetes, tissue viability, respiratory problems, smoking, the list goes on. The aim here is that someone can live well even with multiple physical health conditions. So just a little bit about our organisation then. Sheffield covers a population of roughly 750,000. We've got a large area and we support a lot of people. So this could be in emerging care, crisis or ongoing management of conditions. As a trust we have both community and inpatient facilities. And we usually offer services from 18 to 64 and then 65 plus for our older adults. We've got 18 inpatient facilities that spread across our services. They go from acute, forensic, rehabilitation, nursing care, dementia, and we've got 37 community teams across the city. At any one time, we can accommodate roughly 270 patients in our inpatient facilities. We've got a very varied demographic within Sheffield. So community delivery is often tailored to the need of that service. We're not associated with any other acute hospitals, but have close links with our Sheffield Teaching Hospital. So this is the staff bit now. So our staff organisation, we've got about 3,000 substantive staff, and we do have to use a lot of bank and agency. That does make up a proportion of our staffing numbers. As a mental health trust, our specialism is to support in mental health conditions. We are not experts at managing physical health, but we need to have a robust understanding of how urgent or emergency care is managed or as it's required. As a trust requirement, every member of our staff is either basic life support trained or ILS trained yearly, and a number of other training compliances must also be met to kind of match the physical health need. We're introducing a clinical skills framework for all the staff, including non-clinical staff, for how to recognise a deteriorating patient and how to respond. This will be a key skill, especially with the service user demographic that we support. So as with other services, I'm sure it will come as no surprise that the NHS, we struggle with staffing and retention of our staff. It's often related to stress or injury from work-related issues. Workplace wellbeing and occupational health oversee and manage this. The lack of some substantive staff in some areas does mean that there is often a heavy reliance on our bank and agency network. So I'll pass you over to Mo.
Yeah, hi there. We have a core framework of services that we have within the trust, but we have a sort of overarching sort of policy to do with physical health and a physical health sort of strategy over a number of years. But this sounds quite easy to do, but we have to do the policy but split it into 4 different areas of different care settings. And the focus is to is the different needs of that specific demographic for the service users that we care for. So in our acute areas, we've got 7 working age adult acute wards. So our PICU, which is our psychiatric intensive care unit. These are for people who are experiencing a crisis and severe mental illness or decline in their health and require some form of immediate intervention. And we offer that in a safe, supportive environment to hopefully then monitor and stabilise their conditions. This may well be through medication or more encouragingly we're trying to do it through supportive therapeutic services rather than relying on medication. But physical health is more than likely to be a contributing factor in these conditions and more than likely it's going to suffer due to neglect or decline in their mental health, that they're not looking after the physical health condition. So that's a challenge within our environment, is the patient's not going to be compliant with our physical health intervention on their admission. So we need to ensure that their physical health care is not deteriorating to a point where we are unable to deal with that physical health condition. Predominantly our staff are trained in mental health and not in a physical health care setting. So they lack a lot of confidence in dealing with a physical health condition and monitoring because it's not their speciality. Our speciality is their mental health. So we have a number of challenging behaviours, especially in our older adult dementia care wards, which we've got 2 assessment wards and then into our nursing homes. So as a trust, we have continuing to improve the skills and knowledge of the staff in sort of that general nursing care and encouraging that collaborative working. As I say, we're not the specialists, but we have got specialist teams within primary care. So we encourage those working relationships with those specialist services so we can early detect any physical health deterioration and prevent any worsening symptoms. So the next core framework of areas we've got is rehabilitation and step down. So coming from potentially that prolonged period of stay in an acute area, they still need that support, but we need them to get our service users to enable them to work on living with their condition on their own without our full support and become more independent and hopefully going back into the community and living well within the community. And the challenge here for us here is that having the staff to be able to step back and not do a lot of interventions, but maintain that, that positive care, that positive risk taking. It's difficult for the staff not to intervene. We have to go down the line of having some form of positive risk taking built into the care. There are established sort of well evidence referral pathways we can encourage our service users to use, so then they can live with a more independent life and self-care for their physical health condition as well as their mental health condition that they have. And establishing that the patient's own knowledge of their conditions as well. Just because we understand it doesn't necessarily mean that they understand it. So we may have to go down the line of do they understand what the physical health condition is and how that affects their mental health. It's important for patients to be given the opportunity to self-manage their own conditions in their physical health. We've also got some areas that are in our forensic areas, so patients who have become under restrictions from the Ministry of Justice, so they come onto our areas. They may have a long sort of offender history or there's a significant risk to the public, and we have to deal with their physical health and mental health conditions and step into those rehabilitation services, because they may have a long period of prolonged mental health support, but in a variety of rehabilitation areas to get them back into independent living in the community areas. The big challenge here is the unpredictability of those areas. It's really the staff safety element. These service users potentially have high risk profiles, so it's maintaining staff safety, encouraging them to service users in the rehabilitation journey. And it is a journey of rehabilitation for those service users, giving them the tools and the skills to sustain a healthy lifestyle. And again, it's important to give them the responsibility to look after their physical health care. Our biggest cohort of service users are in the community. I think a lot of the focus is on the inpatient areas. Just like physical health care, all the focus goes on the acutely ill, but the majority of customers, service users, are in the community setting, and that covers a large variety of physical health needs and diverse backgrounds. Community service are multidisciplinary teams. It's not one size fits all. So the multidisciplinary, a wide range of professionals within each team: nurses, occupational therapists, social workers, psychologists, vast amount of skills and knowledge. The challenge here is gaining the trust and the engagement between the patient and the staff, maintaining that working well within the community setting. They live chaotic lifestyles, don't they? So it's encouraging that engagement, but not being too controlling of them, as it were, getting them to ensure they can effectively manage their lifestyle and their physical health conditions and mental health conditions. And it's helping manage those conditions and recognising they're becoming physically unwell. They might not recognise that, and we need to intervene and recognise they're becoming unwell and put in that supportive mechanism that they may require.
So within our organisation, there's lots of challenges to providing care. So as you can see, some of them are our resources, numbers of staffing, which we've already talked about, staffing confidences, because again, physical health is not our specialism, the environmental challenges we have on our clinical areas. We're very short on space, and a lot of the kind of bedrooms where they need a lot of equipment, they just don't have the space. I guess the access to appropriate assessment as well. We do refer on to a lot of specialist services, and it's, I guess, we're waiting for their timely response to be able to act upon that. We have a lot of rapid or unplanned admissions, and it's how we manage that. And then, I guess, lack of onward placements, really. We've got a lot of people that have been kind of sat in services for a number of years, but the options for them to move on is very limited. So some of the risks that we've got as an organisation. So our quality of care and patient safety should always be of utmost importance and a priority, and as well as managing our staff, but can be particularly challenging in some of our settings. Obviously, we've got to maintain staff safety. Our daily challenges that we face, that we see every day, can be anything from challenging behaviour and intimidation, physical and verbal aggression to others other patients, other staff, use of ligatures, which is very high, self-harm, which is very high, head banging, which is becoming quite a popular form of self-harm for some of our service users. Falls management because of our older adults areas. We have service users that go on leave and then the risk of them going absent while they're on leave and how you manage that. The smoking restrictions has caused a massive problem for some of our inpatient units. Obviously, we're now non-smoking. That doesn't really go down well with a lot of our service users on our wards, which just causes its own problems. And then if there's leave restrictions, so people can't access that Section 17 leave, they can't exit the property, that brings its own challenges. So we do try and do quite a lot of proactive working. It's vital that such cases that what we've mentioned can be dealt with in a multidisciplinary way in order to ensure that appropriate actions are taken for both our patients and staff. This could mean increased staffing, but we've said that there's challenges there. Enhanced observations, increased training that we're working on, incident reporting. We're very keen on staff reporting any incident so we can kind of monitor and review these. As part of our risk and incident management, the whole trust has a daily incident huddle. This is a rapid response group, so anything that's come in the last 24 hours that's been raised across the whole trust, that's community and inpatient, is reviewed by a team of specialists. And then anything that's urgent can be kind of picked up and identified on the day. What we found as well is that a lot of clinical teams also have their own daily safety huddles or hush huddles. And again, that's to discuss any immediate safety concerns. And that happens in both community and acute or inpatient services. Mo's done a couple of scenarios just to explain some of our kind of issues that we work through on a daily basis.
Yeah, so as Sharlene just mentioned, self-harm is one of our biggest sort of unplanned events that occur within our embedded patient areas. So, I thought I'd give you a little scenario of what the challenges that this faces the staff. So, the scenario could well be that, a young female under Section 3, which has just been detained for a mental health assessment for up to a period of time, has been found with a ligature around her neck. So why is this challenging to us? And the biggest thing we're finding is the fact that this is occurring on a regular basis, and we're maybe talking 8, 9, 10 times a day with various service users. So, how do the staff react to that amount of trauma every single day, and being compassionate around that? So that's a massive challenge, isn't it? That's not really very well spoken about. So the staff have to raise that alarm, don't they? They have to notify and get help. So we've got, they all have personal alarms. So we can raise that alarm, but these alarms going off 20 times a day. I'm busy writing a report, or I'm busy writing someone's care records. That alarm's going off again, or somebody else will get it. There's that massive risk of complacency, isn't there? Yes, we all have got emergency equipment available to us on every ward, but that has to be kept safe. We can't have emergency equipment available to service users. That has to be locked away. Sharlene said earlier on, we have a lot of banking agency staff. We need to get access to all areas. All of our doors on our wards are anti-barricade, so they can be opened both ways. So again, these service users find ingenious ways to make it difficult for our staff. So our anti-barricade doors, they open both ways, so there's no way they can barricade themselves into their room.
They still can have a little go.
They still challenges every single time, yes, yeah. But then, the patient is not going to be, oh yeah, come and just cut it off for me. They're going to be resistant to that. Okay, so that's a massive risk that we have to use an element of physical restraint, and we've got a massive training package that all staff go through in the techniques of physical restraint and maintaining that person's dignity, because that is trauma for that person, isn't it? As going to lay hands on somebody to remove something around the neck. We know what we want to do, but how we deliver that care in a compassionate way. Because the patient, after they've removed that ligature, they're not going to just sit there and let somebody do their vital signs and take their pulse and blood pressure. They're going to be non-compliant with that, aren't they? They're going to tell you to get lost very quickly. So how do we ensure their physical health is maintained and not become, they're being uncooperative because they've got a physical health emergency going on. And then also there's that element of de-escalation. What's caused the person to do this? And there's an element of de-escalation in maintaining that patient's safety for the rest of the day after that. All right. So we found that there is a lot of tools out there that we can do monitoring someone's vital signs, but the evidence tells us that is if the patient is compliant and lets you do it. What if the patient doesn't let you take their pulse? Okay, so, or lets them count the respiration rate because they're hiding under a blanket. How do we know that that person is still safe? So that's the challenges we have with News 2. We've had to come up with a modified version of News 2 to ensure that person is in the correct, safe place.
So, as a trust, we support a lot of people with comorbidities. As we've mentioned before, mental health is no longer isolated as a solo issue, and often our patients in both community and inpatient facilities have a number of comorbidities. It's just the lunch van. Staff can find this challenging as part of physical health team. We're a very small team, we're only 6, and we have to try and offer support to the trust for education and guidance. Our mental health services are predominantly supporting patients with severe mental illness, and it's well recognised that patients suffering with severe mental illness have physical health comorbidities. So this could be anything because lifestyle, lack of understanding, the demographic inequality. There's lots of different reasons for that.
So I've spoken about a scenario that is quite I wouldn't say extreme, but people just don't really understand it goes on and don't want to think it goes on. So I'll give you another example of the challenges we have within the acute setting. Someone may need our services. Sorry, can you? May need our services. We've got a lot of pre-existing physical health conditions. What happens if the person's in a wheelchair, is wheelchair bound, and has been refusing all care within this community setting or his care setting? So he needs to come into one of our wards. This in itself causes a lot of issues, but we need to be proactive in dealing with that multidisciplinary sort of way of making sure both the patient is safeguarded in terms of their own care and the staff have got the knowledge and skills to deal with this person who has got, who may be wheelchair or bed bound. But as Adela, this is anxiety inducing for the staff. This is not their speciality, and that creates a lot of anxiety. That creates a lot of additional training on a very small team of the physical health team, and the additional equipment, and that may require. How do we keep that equipment serviced and safe within a very volatile potential area? But we shouldn't be taking over the expertise of that physical health care. We need to make sure they manage that well and are safe, but we need to have access to the specialist if we need to, whether we take that specialist teams in to support us or we take the person to there. So we're essentially making sure that the patient's mental health returns to a stable level that they can then function effectively back in the community setting. Once that person is more stable, the staff can then move on to the community teams, and then that knowledge and management goes on to the community teams. And hopefully the patient is discharged within months rather than years and years and years of waiting until their mental health gets better. It's a lot of collaborative working going on at the same time, rather than I'm going to treat your mental health and then we'll treat your physical health. There has to be that collaborative working, both working at the same time.
Okay, so just lastly, our take-home messages then. Care delivery and support may need to be adapted dependent on patient need. We encourage active conversations about continued patient care. Take guidance from the staff teams working with patients, as they're the one that get to know them the best. Make every patient interaction count, even if it's just a hello. Problems or issues can always be worked through. Seek support when it is needed. And delivery of patient-centred care is key. Thank you very much.